about pre-op assessment. Andy's going to talk about ABCDE assessment, and then we've got Simon Fleming to go 2 hours through surgery, which is... He texted me last week and said, right, next week, 3 hours to go through surgery. I was like, no, 2 hours to do surgery. So, beware. Okay, so pre-op assessment came up quite a lot in the survey we sent out for you guys, saying things you were worried about for finals. So hopefully this will help you just get a structure in your head. There's only a few bits of new information, really, and the rest of it is just structuring what you already know for when it will come up in finals. It keeps coming up in different demises. I think the main time it comes up is in the main OSCE, because then they can do cardio and respiratory together, so examine you on more things. That seems to how they've done it the last few years. But there's a few other times it comes up as well. It's important in real life, in hospital, because it reduces cancellations, I think is probably the main reasons. But also you can optimise patients ready for their surgery. So how we're going to do it today is, again, try and do it with a case, but we'll bring in the important bits. So when you're an F1, most surgical F1 jobs include a pre-op clinic. What would you guys do when faced with this question? Please perform a pre-op assessment on this 85-year-old lifelong smoker who has been booked for a resection of his enlarged prostate.
Take a history, maybe do an examination instead of investigation.
Fantastic. So just like everything, we're getting there now. So history, examination, investigation, and then there's some management things that you'll do. So get a structure. Now, hopefully all of you have got these structures in place. It just means that in finals you can not be too dazed and confused. So let's go on to the history. So this is our gentleman, admitted twice for retention in the past year, and so now he's got a long-term catheter in. He's got enlarged prostate, and his PSA was just marginally elevated. So you take a history. I won't read it all out, but what's in this history strikes you as important, not just generally, but in a pre-op assessment? So blood thinning tablets. Yeah. So he's a smoker. Why is that important?
Sounds like he's got COPD, so airway, breathing, it might be a bit difficult for the anaesthetist.
Yeah, good. So taking that one step further, so it sounds probably like he has COPD. So we need to think about the respiratory system, and in terms of anaesthetic risks, there's some there. Anything else?
He's got reflux, so he's at risk of respiratory pneumonia, he's intubated.
Yeah, wicked. So down here, he's got the acidic taste, so the symptoms of reflux. So there's risks of aspiration there. Anything else?
Never had a previous operation.
Yeah.
We don't know how we react to general anaesthetic.
Good. I think you all heard that. So no previous operation is as important, because it just means that we'd have to start afresh. If he's had a big operation last week or last year, then we might have a lot of the investigations and we'll know what his, how he can tolerate the anaesthetic. Anything else before we move on? So I think we've got most things. What's his pack year history? So yeah, so we had one person say 140. Rest of you said 70. So yeah, 70 is right. Ward controlled. So his baseline dependence is already not perfect. So if we're then going to think about putting him through a reasonably large operation, we need to then think about involving other teams, so the OT team, social team, whether he'll need an increased package of care. So that is important, and everything else I think we got through. So he shows you it's really useful to ask for their repeat prescriptions rather than just trying to get them to remember names. But kindly he has given them. What stands out here is important. So anything here that you would be concerning in a pre-op setting? Warfarin, definitely. So we'll come on to that in a minute. And with the bleeding risk also, yeah, so the aspirin. Say that again?
Ramapril?
Ramipril, yeah. And more than that? So Ramipril on its own, is that important? Yeah, why? I can't see who I'm speaking to. But hey, hi up there.
You shouldn't have ACE inhibitors on the morning of the operation.
Yeah, well done. So ACE inhibitors you need to stop on the morning of the operation. We'll come on to why a bit later. But what else is important? So he's on not one but 3 antihypertensives. So that shows that he's a poorly controlled. He's got poorly controlled hypertension. Anything else there?
TCA.
So TCA. So
The tricyclic
yeah.
because that could predispose them to reactions with the anaesthetics and some of the other drugs.
Okay, I wasn't aware, but apparently a
Neurotype reaction.
TCA apparently can affect anaesthetics. Wasn't aware of that. So yeah, we'll come on to the warfarin. But so his COPD, which we're assuming he has, is also poorly controlled. Has 3 agents required. So how do we? So he's on warfarin. When would we stop the warfarin? Would we stop the warfarin? Anyone? So 7 days. So it's called bridging the warfarin. So we'd stop 7 days before, and then what would we do after that? So we've got here, so we'd stop it, and then we'd put him on low molecular weight heparin. Does everyone agree with that? Yeah? I think that's the most sensible, and that's what most of us would do. You can, if it's a lower risk reason that they're on the warfarin, you can just stop the warfarin for a week and put them back on it. But I think for all of our levels, we just say stop it, start heparin, and then what do we do? So we started them on heparin, and then we just operate on them. So check the clotting, a bit more specific. So the INR. So some people might be on WAC in great doses or have poor renal clearance of their warfarin. So you need to ideally check the day of, or ideally the day before the operation to check their INRs reduced enough, and below what level is appropriate or okay. So yeah, 1.4. So anything below 1.4 is most surgeons would be happy with that, or most anaesthetists would be happy with that. And if it's not, then vitamin K obviously can bring it down further. Then you stop the Clexane the day before the operation. You do the operation, start back on Clexane, and then when do you start the warfarin? So you've stopped it a week before. So, week after. It's just a day after would be fine, unless there's any ongoing risks of bleeding. And then when do you stop the heparin? Good. So once the INR is in range. So does everyone understand that? So it's called bridging. So you take out the warfarin, you bridge it with low molecular weight heparin, and you stop it. Check the INR's low enough for the operation, start it, and stop the heparin when the INR's back to target range. So here's some other medications that might be useful. Just quickly shout out, if you know, if you're not sure, when would we stop aspirin? Okay, so we'll stop aspirin a week before as well, unless there's a high risk reason for them to be on aspirin. And if there is, then you just need to ask someone else who might know, anaesthetists, cardiologists, or whatnot. Therapeutic heparin, you stop 2 days before. Again, unless there's a high risk indication. Insulin. Yeah, so you can use, depending on their control, most people would either admit them the night before, or if they're having a later operation, on the day of, to put them on a sliding scale to control. Hypoglycemics. So you just don't give these on the day, and metformin you won't give for 2 days before or 2 days afterwards. And then ACE inhibitors, we've mentioned up there that you avoid that on the day of the operation. Then other medications. If there's anything else on the medication chart, you can say that as an F1 or in OSCEs, you'd just say you'd liaise with the parent team, the team who started on the medication, and the anaesthetic team. And that's the safe way to do things. So in terms of the history now, in terms of their current state, what would you want to know about how they are now? Okay, so exercise tolerance. Anything? Any coughs or colds? So that's really good. So generally, how are they on a day-to-day basis? How far can they walk? What can they do around the house? And then more acutely, in the last week, have you had anything else new? Any coughs, colds? Are you feeling awful? Is there any reason we need to delay this operation if we can, is basically what we're looking at. So what's their baseline? Obviously, then, what operation they're having is important, etc. Past medical history. Do you just want the list of what their past medical history is, like you would in another history? Yeah? Or do you want, what else might you want to know?
Things like sleep apnea, so airway specific problems.
Yeah, brilliant. So really the two systems you're looking at are airways, so sleep apnea, cardiovascular and respiratory, the main systems you look at. But the most important thing is how they're currently controlling them. So this gentleman might have, you often hear people say, I used to have hypertension, I used to have diabetes, when it doesn't mean that they just don't have hypertension because they're on 3 medications for it. And you'll often hear that. So how are they currently controlling these conditions? We've talked about any surgery they've had before and any anaesthetic they have had before, and obviously the complications. So be really strict. Go through the past medical history. Everything they say, I've got diabetes, how are you controlling that? What's your current control? I've got hypertension. And just go through really systematically. Then what surgery have you had before? Then go through when, because in an OSCE they're not going to have a long list. So it's there so you can do that. Drug history we've talked about, and make sure you talk about their allergies. Why is family history important? So malignant hypothermia, incredibly rare anaesthetic complication, but it does run in families. And then social history we've touched upon. So smoking, what their level of dependence is, because usually for either a small amount or long amount of time afterwards, their dependent level will go down, and then their exercise tolerance. And then anaesthetic specifics, so mainly on the airway, it's worth mentioning about dentures and dentition. So what would you do to examine in your examination? So this does come up. It has, I think, 3 out of the last 5 years or so. So a pre-op examination in OSCE, how would you structure that? Yeah, so good. So, and then just, have you all practiced doing a cardio and respiratory together? No? So anyone, have you practiced that? How would you, or have you got an idea how you'd structure that?
So you do the peripheral side, but you include the both systems, I guess. And then you just go to the chest systematically through respiratory and cardio, all vice versa.
Yeah, so I think that's the most straightforward. So do the peripheral, so do the hands, the arms, the face, the neck together, because then you can just name the different systems. And then when you're on the chest, either do all of respiratory, front and back, all of cardio, but I think it's probably smoother to do the front cardio at the front, respiratory, and then do both on the back as well. And then mention things. I think things like the anaesthetic, airway things, you're not going to be asked to fully assess them, but just it's maybe a gesture to say, can you open your mouth, and they'll be able to open their mouth fully. You can say, look like you at least care. I won't dwell on this because so this gentleman's examination, so obviously has tar staining, irregular pulse, and a wheeze throughout. Observations, would be happy with them. Pre-op. Be confident. SATs are low, but he has COPD. So SATs are normal, really, aren't they? That would be in our target SATs. So yeah, we are happy with them. His heart rate's fine, his blood pressure's fine. So in terms of examination, I think to structure your examination, like we just said, is good. But when you're presenting, it can sometimes get a bit difficult to present them both, especially with some abnormalities. And I think doing, in your mind at least, A, B, C, D is reasonable. So you can say airways. What's the name of the, because that could come up in an EMQ, what's the name of the classification for opening your mouth? Good. So structuring it airway, then breathing, i.e. the respiratory system, C for the cardiovascular system, and then the BM and a BMI would be reasonable. So for this gentleman, 85-year-old COPD, what investigation would you, and he's having a reasonable operation? ECG, yeah, definitely. Spirometry. Bloods, what bloods?
FBC, UNE,
So- Okay, so FBC, happy, why? Yeah, because he's probably going to lose a bit of blood. U's and E's, why? Because you're going to give him lots of drugs. Baseline. Baseline's a reasonable thing unless you've got a horrible consultant and they'll say, baseline. But he's on antihypertensives, which can obviously alter. And if he hasn't had a use and ease, it might have altered and he just doesn't know. And also he's going to have a reasonable anaesthetic. So that would be a reasonable reason why. Anything else? And group and save. Group and save or cross-match for this guy? Group and save, yeah, I think so. Anyone in this room not happy with the difference? Please say no. Good. Okay. Anything else? So we've got those bloods. Clotting, we said. So INR, yeah, included in that clotting. Not really any other bloods you can do. Anyone doing LFT? CRP? Anyone? Do those two? No, I wouldn't. Then we said an ECG. Anything else? Chest X-ray, definitely. Basically, you kind of get the gist. It's basically every investigation you can think of. Just make sure you structure it. So the NICE guidelines have a little system. So I think we got most of these. So you just put in their age, their ASA grade. So as long as there's a computer next to you in your OSCE, you can just type them in. But yeah, so we got most of these. It says consider a blood gas, but obviously I wouldn't agree with that in this patient. And lung function tests. So again, try and structure them. I know I was asking for them to be shouted out, so of course you weren't going to. But make sure you structure your investigations. So these are a list of basically all the investigations you'd consider. I think most likely in your OSCE you'll get someone who's either really old and really crumbly, or no, I think that's probably all you'll get. And so you can just remember this list and churn it off. They'll never, especially in finals, never criticise or mark you down for going over investigations, so being over safe. So I think to do all of these in most of your scenarios. No one mentioned an echo. Might be worth, because he did have a murmur. Okay, so what does this ECG show? AF, good. What's the rate? Yeah, it's quite difficult to see the squares, isn't it? So yeah, just remember the two ways. So we could count all of these QRS, times them by 6, that's 78. Or you can go the ones that are closest, and the ones that I think I worked out yesterday was, I think, 80 to 60 to 100. Sorry? ABG, we're happy with that? Not happy with that? Anyone? Yeah, we're happy. So what would you be unhappy about on it? Well, what does it show? It's easier. So type 1 respiratory failure. Anything else? Yeah, that's a good spot. So a bit polycythemic. Not really important in this, but yeah, so I'm happy with that. His oxygen requirement is noted, so for surgery that would be important. And his clotting, why is his PT elevated? He's on warfarin, good. So this would be fine. This would be appropriate for his pre-stopping the warfarin, and then on the day before, like we said, it needs to be below 1.4. Chest X-ray. Flat diaphragm. So with all these investigations in OSCEs, in exams, in finals, it's all going to go along a really smooth path. So you could have read the history at the beginning and without looking said what the chest X-ray is going to show, what the ECG is going to show, what the ABG, what the bloods are going to show. And so when you're looking in for exams, just imagine this is going to be a COPD chest X-ray, and it is. So they're not going to throw big curveballs. And obviously then you're looking for something rather than some people might have just said, oh, it's normal, or thought about consolidation, but his history wouldn't fit that, and in finals it will fit, I promise. You can't really read that, can you? No? Excellent. So you got away with that. So look at these. This is obstructive field on a lung function test. So they could give that. So the big printout, big scary printout of the lung function test. And so just make sure you're aware of which of the three lines you need to look at. Kindly here, they're in bold, but they might not be. Because they'll just try and wean out who of you have looked at the full printout or not. So yeah, the NICE guidelines, this is actually what they are for what tests you need to do. It's an absolute nightmare. So which tests you do, generally, you guys, like we've gone through, it's quite common sense. But it depends on the patient and the operation. So in terms of the operation, we grade operations minor, intermediate, major, and major plus, which is basically a major operation that needs to be done by a specialist surgeon. So let's play bingo. So which grade of operation would excision of a skin lesion be? Yeah, good. Hysterectomy? Oh, lung operation. Oh. Blundered. Drainage of a breast abscess? No, 1. So it's just a little abscess. Varicose vein? 2, 3, 4, we've got? Yeah, 2, I think. Yeah, because it can bleed is the big risk in that. Total joint replacement?
3, 4.
Oh. Could any surgeon do that? No. Need Mr. Fleming. Tonsillectomy? 2. Thyroidectomy? 3. Yeah, that's a bit cheeky, isn't it? You can see where the gaps are now, can't you? So hernia repair? 3. 1. 1. Bloody hell. And then our man who's having his prostate removed. See the gap. So it kind of makes sense. The minor ones are easy, the major plus are easy, and like all scales, the ones in the middle are a bit more difficult. Just have a stab. You don't need to remember the grades, but say this gentleman's having a major operation or an intermediate. It just makes you sound a bit cleverer. What's the system you can assess the patient on? Okay, ASA. So grade 1 to 6. What's 6? Dead for organs. Yeah, normal healthy patients 1, and increasing mortality, as you'd imagine. I was really surprised that a moribund patient unlikely to survive 24 hours with or without surgery only has a mortality of 10%. Great, isn't it? Because that surely means that if they're going to die within 24 hours, just do the operation. It makes them, I don't know. Anyway, so this patient, what ASA grade? 3 or 2? Okay. Let's have it out. Hands up for 2. Hands up for 3. Oh, it's literally 50-50. So, if we go back to... So it's mild systemic disease. So again, it's the ones in the middle are going to be difficult, but he's got asthma and well-controlled diabetes. We'll come on to... There is a bit of variation in that. You wouldn't get marked really down in that for... Four? Any changes on 4? 3? So he had an MI a week ago, and he's still got valve dysfunction. Yeah, so there's the one. So poorly controlled condition would class it as severe. Asthma and well-controlled diabetes. A lot of people have that. Controlled. 1. So if you smoke more than 10 a day, you're 2. If your BMI is above 30 or 35, you're 2. And if you drink too much, you're 2 as well. So it's easy to mess up. Yeah, 5. And then, like we said, brain dead, 6. Okay, so again, these are just for you guys to look through, but it's quite common sense. 1 and 4 and 5 and 6 are easy. The ones in the middle, 2 and 3, are a bit more difficult. And so these are some examples of common diseases. But it's basically, so if we take hypertension, using one agent is mild, severe is either not controlled or using multiple agents. And it's similar for all of those there. So which tests, just quickly I'll go through these. So an FBC you do on most people, but the NICE guidance say that it should just be on everyone who's over 60 or women who are of childbearing age because they might have anemia. Or if you're planning to lose or estimating to lose, you'd never plan to lose a lot of blood. Using these if either baseline, if you're expecting a lot of blood loss, or if they're on medications that might suggest ECG, women over 50, men over 40, or if they have significant medical conditions or on medications that might give you ECG changes. Chest x-ray, anyone who has anything wrong with their heart or their lungs gets the chest x-ray. Sickle cell, anyone who's not white gets a sickle cell check. And then we've talked about a group and save or a cross match. So just a few things now, the last couple of slides. You need to make sure you order a pregnancy test. Make sure you say that. And MRSA swabs, that probably won't be a mark in your OSCEs, but make sure you say it. So the CPOD list, so that's the theatre list. So it's reasonable to know these. So they're classes 1 to 4 on severity of how quickly you need to do the operation, 1 being now, so if it's life or limb threatening, down to 4 being elective. And then think about where the patient's going post-op. So if they're unstable, they're likely to need an HDU bed or an ITU bed. So basically the whole purpose of this is to optimise the patient for the operation. So diabetics, we've talked about sliding scale or controlling their blood sugars. Put them first on the list because they're going to be starving. Thromboprophylaxis before, sort it out, and make sure you've prescribed afterwards for Clexane if they need it. And review the bloods if they need a blood transfusion or whatever. Involve the MDT. Always say that in OSCEs, histories, or examination, whatever you're doing, involve the MDT. So for most pre-op patients, involve the anaesthetist and social care for post-op. When do you need to stop eating before an operation? 6 hours. And last drink? Last cup of tea with milk? 4. 6. Just say 6. Basically anything that's not clear fluids, 6 hours. Drinking clear fluids up to 2 hours. And make sure they're consented. So in terms, it's a bit of a whistle stop, but I think you'd agree nothing that new in it's just make sure you have a structure so you don't get a blank face when it comes up in OSCEs. Structure it like you would everything, history, and then your history structure, examination, your examination structure, and likewise for investigation and management. And is there any questions on anything we've talked about there? No? All happy? Good.